Welcome to Roadmap to Residency. Hello everyone, I'm Abhiraz. Welcome to our Club 250 Matchmaker sessions. We are starting our neurology part. This is the Neuroanatomy Fundamentals part 1. We will be running through some questions with you guys to help you on the journey to a 250. So, which of the following describes the location of the primary pathology in this patient's neurological symptoms? A 32-year-old woman presents with weakness, numbness, and difficulty coordinating movements in her right arm. She also reports visual disturbances and difficulty swallowing. On neurological examination, there is weakness and increased tone in the right arm, and the right side of her face appears droopy. MRI reveals demyelination and inflammation in the white matter of the left cerebral hemisphere. Which of the following best describes the location of the primary pathology in this patient's neurological symptoms? Peripheral nervous system, spinal cord, central nervous system, autonomic nervous system, or enteric nervous system. So the clinical presentation, including weakness, numbness, visual disturbances, and difficulty swallowing, along with demyelination and inflammation in the white matter seen on MRI, is indicative of multiple sclerosis. MS is a disease of the central nervous system characterized by demyelination of nerve fibers. Therefore, the correct answer is option C, central nervous system. Now, I will tell you some of the basic things and also how to approach a neurology question in your USMLE step 1 examination and also in your self-examination. So the nervous system is divided into central nervous system, which consists of brain and spinal cord, and peripheral nervous system, which consists of cranial nerves and spinal nerves. Again, the PNS is divided into autonomic nervous system, which supplies the heart, smooth muscle and glands, and somatic nervous system, which supplies voluntary skeletal muscles. Now, the autonomic nervous system is again divided into parasympathetic division and sympathetic division. Parasympathetic division is the division or the posture, the state that you are sitting in right now, that is rest and digest. And whenever you are active and alert, the sympathetic division works. So the major components and functions of the nervous systems is explained in this picture. So whenever we apply the receptors, okay, now receptors are sensory structures that detect the changes in the internal or external environment. So whenever the receptors get stimulated, there are visual sensory receptors or somatic sensory receptors or spatial sensory receptors. Then the sensory division of the PNS brings information to the CNS from receptors in peripheral tissues and organs, okay. After that, the information is processed in the central nervous system. Then the motor division of the PNS carries motor commands from the CNS to peripheral tissues and system. It includes the somatic nervous system and the autonomic nervous system. The somatic nervous system then controls the skeletal muscle contractions, which then acts on the skeletal muscle, and the autonomic nervous system provides autonomic regulation of smooth muscle like cardiac muscle, glands, and adipose tissue. So depending upon the stimulus provided and the receptors stimulated, this is how the basic flowchart of the central and peripheral nervous system works in association. Now, the effectors are the target organs whose activities change in response to neural commands. So receptors, PNS, CNS, then again PNS, and then again effectors. Now, let's talk about parasympathetic and sympathetic system. Now, the parasympathetic system is when your body is at rest. So your pupils are constricted, there is increased saliva production, there is reduced heart rate, there is constriction of bronchi, there is stimulation of the digestive organs to digest the food, stimulation of the activity of the pancreas, stimulation of the gallbladder. There is constriction of the urinary bladder, and that stimulates the erection of genitals of man and woman. So we have seen in movies that whenever the villain is scared, then he pees in his pants. But that is completely wrong. When you are scared, you cannot pee in your pants because in sympathetics, being scared is a sympathetic state, and in a sympathetic state, your bladder does not contract, it rather relaxes. Also, you want to see wider area, so that's why your pupil will not be constricted, it will be dilated in case of parasympathetic system. You know, when you are scared, you are going for an interview, then your mouth becomes dry, okay. Now that is because of the sympathetic system activation that inhibits the saliva production. Now that you are resting, the saliva production is normal or increased, okay. There is tachycardia when you are sympathetic, Okay, there is stimulation of digestive organs when you are in the rest position, and also you cannot think of sex when you are in a very dreadful situation. For example, a lion is chasing you, you will not think of sex at that position. That is the sympathetic state. But yeah, you may be involved in sex when you are in the parasympathetic position. So sympathetic can cause dilation of the pupil, inhibition of saliva production, dilates the bronchi, raises the heart rate, inhibits the activity of digestive organs, inhibits the activity of pancreas, and inhibits the gallbladder. It stimulates the adrenal medulla to release adrenaline and noradrenaline, that are the stress hormones, and then it relaxes the urinary bladder so that you do not pee in your pants. And there is a stimulation of orgasm in genitals of man and woman. So remember, whenever there is orgasm, okay, there is erection is related to the parasympathetic system, but orgasm is related to the sympathetic system. Now, this is how you approach a neuro question. So first of all, you need to find out, is this a central or peripheral nervous system issue? So perhaps one of the most important distinctions that can be made initially when characterizing neurological issues is if the complications arise in the CNS or the PNS. So what makes us suspect the CNS involvement? So if a patient has symptoms relating to any of the following components, then some aspect of the central nervous system must be impaired. So if it is a neurological issue, so if the patient has a level of consciousness, decreased level of consciousness, if there is issues coordinating movements, like if there is some lesion in the cerebellum, if there is difficulty initiating voluntary movement, like for example basal ganglia, complications with speech and language, behavioral and personality changes. Now these symptoms make us suspect that the person is having CNS involvement, and these clues will be given in your USMLE question to let you identify whether the question is of CNS or PNS type. Now, which processes can be either CNS or PNS? So if the following symptoms are observed in a patient, both CNS and PNS issues might be responsible. For example, motor pathway defects, sensory pathway defects, visual complications or disturbances, hearing issues, impaired sense of smell, taste impairment, facial sensation complications, movement of facial muscles, and these processes, all these asterisk processes involve the cranial nerves, right? So there are few key findings that can help differentiate between the lesions that affect the CNS, upper motor neurons, and peripheral nervous system, lower motor neurons. Keep in mind, issues with either neuron can cause weakness in the muscles. So upper motor neuron issues, like CNS, can cause hyperreflexia, Babinski sign, increased tone or spasticity, and there is no muscle atrophy at first. Lower motor neuron issues can cause hyporeflexia, atrophy of muscles, fasciculations, and cramps. Okay, this is how you differentiate the upper motor neuron issues and lower motor neuron issues. So this is the dermatomal distribution, also present in your first aid handbook. Now here you can see how the different spinal cord levels supply the different dermatomal parts of the human body. Now, CNS versus PNS sensory pathways. So, dermatomal loss of sensation can be suggestive of damage to peripheral nerves that arise from the specific spinal roots, PNS implicated. Non-dermatomal loss of sensation can be either a CNS or PNS issue. A nerve plexus or individual nerves can be damaged, leading to non-dermatomal issues. PNS implicated, or entire regions of the body can lose sensation due to central lesions. CNS can be implicated. So if there is loss of sensation only in this C5 part, then that means that the issue is PNS. Or if there is loss of sensation in C3, C4, C5, or whole one side of the body, or somewhere else, or it is widely distributed, then that may be a CNS sort of issue. So only one dermatome involved, PNS issues. If any specific dermatome involved, PNS issues. Now, CNS versus PNS cranial nerves. Remember that vision, eye movements, smell, taste, hearing, facial movement, and facial sensation are controlled by the cranial nerves. Symptoms with their involvement can be caused by issues either in the CNS or in the actual cranial nerves themselves, which are part of the PNS. Ultimately, the clinical presentation of the patient combined with the constellation of neurological symptoms can help contextualize if cranial nerve deficiencies are peripheral or central in origin. CNS Does the patient have issues remaining conscious? So if the patient is unable to retain consciousness, then it is very likely that some issue is present with the reticular activating system that is found in the brainstem. The RAS is responsible for keeping individuals awake. And this is very easy to detect. Face it, of the neurological exam can help save precious time in addressing a serious issue. Many different things can cause issues with the RAS, including direct damage and even increased intracranial pressure. The brainstem and likely the cerebral hemispheres should be imaged if there is issue with remaining conscious. So, does the patient have difficulty coordinating movements? Then that indicates a CNS issue. The coordination of multiple movements involve the action of the cerebellum. Patients who exhibit the following symptoms might have damage or impairment of their cerebellum: wide wastegate, nystagmus, intention tremor. So does the patient have difficulty initiating or stopping voluntary movements? The basal ganglia is the structure in the brain that is responsible for either initiating or inhibiting the voluntary movements. Damage to this structure or in the signaling pathways that regulate its activity can lead to both the inability to have a desired movement, akinesia, bradykinesia, such as Parkinson's disease, or uncontrollable flaying movements or hemipalesmus in case of Huntington disease. So does the patient have aphasia or language deficits? So if there is aphasia, it also indicates that the patient is having CNS symptoms. So aphasia refers to the lost ability to understand or express speech. Structures in the left hemisphere are important for language and can be damaged in individuals who have difficulty producing comprehending speech. There are four prototypical aphasias that can sometimes be localized to specific regions of the cerebral cortex, like Broca's aphasia, Wernicke's aphasia, conduction aphasia, and global aphasia. So Broca's aphasia is an issue with regards to expression, not comprehension. Patients are able to understand those that speak to them. However, they are not fluent in their speech, involves the Broca's area motor. Wernicke's aphasia is a complication that stems from impaired comprehension by the patient. They are able to speak fluently, however, typically use nonsensical words and are unable to detect uh, they are speaking gibberish, involves the Wernicke's area or sensory. Conduction aphasia. So patients are both fluent and have preserved comprehension, however, are unable to accurately repeat back sentences that they hear. This involves that the connections are good fasciculus between the Broca's and Wernicke's aphasia or Wernicke's area. Global aphasia is when both Broca's and Wernicke's area are involved. So Broca's is when the patient's words are broken, like I can go to school, something like this. Wernicke's aphasia is when the patient speaks gibberish, like when you ask them what is your name, then they may say, my gardener came to my Jason, and they don't really have that understanding that their speech is being uh, disturbed. Okay, they don't have that comprehension. So, are there symptom of patterns that can help localize the lesion? For example, if there is defects of pathways in the head, so no level of the spinal cord is responsible for innervating the head for motor or sensory pathways. So look above the spinal cord in the CNS for the underlying cause of the symptoms. Cerebral hemisphere. Looking at the homunculus can help us appreciate what types of lesion can bring about certain clinical symptoms. We will discuss about cerebral hemisphere and homunculus in Neuroanatomy Fundamentals Part 2. Arm involvement, much like the face, involvement of the arms in any way will require that a causal lesion be found at above the T3 level of the spine. Given T2 is the last spinal root to innervate any structure in the arm. If a patient presents with any arm involvement, regardless of other symptoms, you must appreciate that at least one lesion must exist above T3, either in the CNS or in the periphery. Opposing loss of facial and body sensation like pain or temperature. The pattern seen below suggests an issue between the pons and the medulla. When the pain or temperature fibers of the face are ipsilateral and the fibers of the body are contralateral, imaging this level of a patient with this characteristic pattern of sensory loss will likely be informative. Now here you can see that this is the cerebral hemisphere, okay? Midbrain, pons, medulla, spinal cord. So if there is damage to like pons or medulla, then that can cause the defect in the opposite sides. Okay. So let's talk about the motor weakness of the face, arm, and leg unilaterally can suggest the likelihood of a single causal lesion in the CNS system. Okay, so if there is motor weakness of the face, arm, and leg unilaterally, okay, if there is unilateral involvement of the face, arm, and leg, then this can suggest that the lesion in the CNS, because how these neural pathways travel. Now, the internal capsule of the brain can be a suspect area of interest in these cases. Okay. Now, there's loss of all pathways. For example, there is loss of both motor and both sensory pathways unilaterally. For example, here in this case, there's loss of motor and sensory pathways unilaterally. Then if an area of the body has deficiency in all of the pathways, only one side of the body, then it is very unlikely that the causal lesion resides in the spinal cord. This is because within the spinal cord, the pain temperature pathway runs contralateral to the innervated area, while both the motor and light proprioception pathways run ipsilateral. If all three pathways were deficient in a patient unilaterally, in order for a lesion to reside in the spinal cord, it would have involved both sides of the spinal cord. That is complete transaction of the spinal cord. That is very, very unlikely in patients. Similarly, loss of pain and temperature with either the motor pathways or the light torture proprioception pathways, deficits in only two pathways, also will likely exclude the spinal cord for similar reasons. Look to either the periphery or above the CNS or above the spinal cord in the CNS for such presentation. So if the patient is having both motor and sensory pathways lost unilaterally, then we have to look for it above the spinal cord level, that may be in the pons, maybe in the midbrain, maybe in the cerebral hemisphere itself. So there are different findings on opposite sides of the body. For example, if pain and temperature is lost on one side and either motor, fine, touch, proprioception, or both have lost on the other side, then the causal lesion is very likely residing in the spinal cord. So what happens is that sometimes the fiber cross, some fibers cross, okay, some fibers go direct. So if there's lesion in the spinal cord here, then the fibers of the opposite side will be lost, the fibers of the same side will be lost. Okay, these functions will be lost. So the patient will have motor symptoms in one side, sensory symptoms in another side. Then this means that most likely the pathology is in the spinal cord. So if there's bilateral symmetrical sensory pain and temperature loss, especially if this loss is only at one level of the body, it can be very suggestive of a central cord lesion. This is because only the pain or temperature pathway will cross over to the other side of the body in the spinal cord. So central lesion in the ventral commissure will selectively affect this sensation pathway bilaterally only at the level of the lesion. For example, if there is central lesion, for example, in case of syringomyelia, then in that case, the patient will be having bilateral symmetrical sensory pain and temperature loss. If there is bilateral motor and pain temperature loss, okay, if there is intact light touch and proprioception, the anatomy of the spinal cord is such that the anterior spinal artery supplies everything except the light touch proprioception pathways of blood. If there is an issue with the anterior spinal, such as an occlusion in the ASA, the patient will lose motor and pain and or temperature sensation bilaterally below the level of the issue. Then this is called as the anterior cord syndrome. Very, very high information for the USMLE step 1 examination. Now let's do one more question here. Which of the following best characterizes the primary pathology in this patient's neurological symptoms? A 40-year-old man presents with sudden onset weakness and sensory loss in his left leg. He reports a recent upper respiratory tract infection. Neurological examination reveals decreased muscle strength, absent deep tendon reflexes, and impaired sensation in the left leg. Non-conduction studies show decreased conduction velocity and prolonged F-wave latency in the affected leg. Which of the following best characterizes the primary pathology in this patient's neurological symptoms? Demyelination of peripheral nerves, axonal degeneration in the dorsal root ganglion, compression of the spinal nerve roots, inflammation of the peripheral nerve vasculature, autoimmune destruction of the neuromuscular junction. The patient's symptoms, including sudden onset weakness, sensory loss, absent deep tendon reflexes, and nerve conduction studies showing decreased conduction velocity and prolonged F-wave latency, are indicative of Guillain-Barré syndrome. So Guillain-Barré syndrome is characterized by demyelination of peripheral nerves, primarily affecting the Schwann cells, and this leads to impaired nerve conduction and the symptoms described in this patient. Therefore, the correct answer is A, demyelination of peripheral nerves. So PNS. Okay, we discussed about CNS, okay, a lot, how we can differentiate the CNS lesions. So where in the peripheral nervous system can this issue be? So if the issue is peripheral, we must decide where in the peripheral system it resides. Maybe in the muscular, maybe in the neuromuscular junction, maybe in the peripheral nerves or spinal loop. So loss of only motor or sensory function. So if only one pathway is affected in the patient, then it is very unlikely the diagnosis is peripheral demyelinating disease. For example, GBS and chronic inflammatory demyelinating polyneuropathy. So the reason for this is because peripheral nerves, okay, both types of sensory and motor travel together in bundles, insist in the same myelin. Should there be a demyelinating disease present, it would be very likely that it will selectively affect only motor or sensory pathways. Now, sensory loss. If a patient presents with sensory loss, the issue is not primarily of the muscles or NMJ because these are not responsible for sensation. Diminished, absent, or reflexes. If a patient has diminished or absent reflexes, then the issue very likely is not in the muscles or the NMJ because only very severe impairment of these components will lead to noticeable differences on physical examination. Present reflexes. If reflexes are present and normal, then the sensory pathway leading to the spinal cord as well as the motor pathway leading to the back of the muscle is intact. Present reflexes do not rule out the possibility of a muscle or an MJ issue. Thank you for watching. Keep studying hard.